not considering an acutely ill patient, but just a regular patient that does need treatment, but you're treating them in the outpatient setting, and we're using steroids, as appropriate first-line treatment. Would you ever, or is there data to add other agents to steroids in the upfront setting?
So at ASH this year, there's a paper presented now giving 14 days of eltrombopag with pulse dose steroids compared to pulse dose steroids alone, and response rates were significantly higher, about 90% in the combination arm compared to about 60 or so percent, 60 to 65% on the Dex alone arm. And at 6 months, this was a 12-week study, so 12 weeks of eltrombopag and 3 months of, or 3 4-day courses of high-dose dexamethasone. At 6 months, over 50% of the patients, I think it was 56% of the patients, were still responding with platelet counts in the, I think the median was like 150,000.
Wow. So do you think that this will become a new approach? Is it too soon to use this approach?
I think what will be nice is next year's ASH, we can see what the durability of that is beyond 6 months. But I think that like we do a lot of combination therapies in many of the diseases that we as hematologists, oncologists treat, and there's no reason not to expect the best response. And so 14 days of eltrombopag is not a lot of eltrombopag.
Absolutely.
Yeah, and I think just to add to that a little bit is that just thinking from a mechanism perspective, especially given that ITP is a clinical diagnosis and we're trying to think of this heterogeneous population of patients that we face with ITP, is that the response rate was nice to see with eltrombopag given in conjunction with the dexamethasone, but just as I think Ralph is alluding to, is that the issue is what is the durability of the benefit, especially in an acute ITP setting where your goal is hopefully to induce a long-term remission in the patient. So that will be a key thing. I think the fact that you gave a thrombopoietin-stimulating agent in addition to a steroidal agent, it's not surprising to me, clinically, intuitively, that it will have a nice response rate benefit, but is that response rate translating longer term, especially when it's only 14 days of eltrombopag? So I think, like you said, stay tuned for what the update may be next year.
And historically, we know that the Dex data would suggest maybe 20-25% 6-month relapse-free.
Right.
So that's really more than doubled.
Well, that'll be exciting to look forward to. Speaking of looking forward to, we are looking forward to the new version of the ASH guidelines. I understand you have looked at this already?
Yeah, so I had a chance to look at it. The ASH guidelines currently, as of this filming, are still in a comment period, so they're not finalized yet, so we may see further changes. A lot of the update, this is the first update in several years for the ASH guidelines for ITP, so it's nice that
at least 5, right?
At least 5 years, yeah. And so I think it's nice to see that there is an update. Some of the key points are the same that I have seen thus far. So the platelet count of 30,000 is still the recommended threshold to consider treatment. Again, as we discussed earlier, the individual threshold for considering treatment can hinge on so many different factors, but that's what the ASH guidelines still say in the preliminary one right now. And they still mention about some issues that we'll get to shortly, that rituximab is recommended over splenectomy for second line or later ITP treatment in the chronic phase. And those are some of the major points. And the other point that hopefully we'll see in the guidelines, but we'll wait for the final version to come out, is how much do they inform clinicians about newer agents that we have available currently, FDA-approved agents that we have currently available that were totally not in the picture when the last guidelines were released several years ago.
That's why we need the update.
That's why we need the update. But I haven't seen much of that section yet, so I think we'll be interested to see if they hopefully include some of those features in the ASH guide, because clinicians are definitely quite inquisitive about how do they utilize these new medications.
Well, it's exactly what you said very astutely, that first-line treatment is not a difficult decision because we know really what to do. But second-line treatment or treatment of refractory disease, that's where guidance is needed, because we have several effective therapies. We don't have randomized head-to-head trials of any of these modalities to help, and treatment is so individualized to the patient.